So, if you put it into the chat, what is communication? Just put what you think or your definition of communication, and why do you think it's so important as a doctor or even as an everyday person? So if people can just, okay, someone put S-bar. Yeah, we will cover that. So what else is communication and why is it important? Yeah, two-way dialogue. Anyone else? Don't be shy. There's no wrong answers here. How we can interact with those around us. Yeah, your communication style is quite essential to an outcome of a conversation, and it will determine how you interact with your colleagues, with your patients, with everyone. Yeah, exactly. It's very important in forming a doctor-patient relationship. It's actually the core of what forms the doctor-patient relationship, doctor-doctor relationship, as well as sort of, doctor and other team member relationship. So communication is something that is definitely very, very important and what you'll need throughout your whole career. So what are some communication methods? So what are some methods of communication that you guys know? Just pop anything into the chat. Yeah, speaking to someone. What else? Verbal and non-verbal. So someone's put verbal, so that can be speaking. Non-verbal, what sort of things can be non-verbal communication? Listening, yeah. Listening is definitely a part of communicating. Body language is very important, yeah. Got very good answers here. Anything else? What are some non-verbal? Yeah, it can be written, it can be form of diagrams, it can be in the form of pictures. So literally verbal and non-verbal. All right. So we move on. So what are we going to cover today? We don't have too long, and this is a massive topic, and I can go on about communication forever. But I think the main things we'll sort of cover today is how to break bad news, discussing DNA, CPR, briefly covering what is S-bar and how to do it, giving family updates, and capacity assessment. So I think before we go on to the other stuff, I think it's very important to understand what is capacity. So again, in the chat, what do we mean by capacity? Because this is something that will come up time and time again when you're working. Does the patient have capacity? Does the patient not have capacity? So what do we mean when we say capacity? Yeah, someone's written the ability to understand and make informed decisions. Exactly. Anything else? Yeah. Are they of age? Why do you think age is an important thing when it comes to capacity? Fit to govern their medical decisions? Yes, exactly. So, yeah. When I asked about the legal age, the only reason the legal age is quite important is, as what other people have said, it does sort of play into whether the question of whether someone understands the information and they're able to sort of weigh options out and make an informed decision. So, by definition, capacity is the ability to use, understand, and retain information to make an informed decision and communicate any of the decisions made. So, all that really means is, can they understand? Are they able to keep the information and repeat it back to you? Are they able to weigh out the pros, the cons? And then when they've done this, are they able to tell you their decision and why they've made that decision? Essentially is what capacity is. And capacity is very important when it comes to communication, because if someone doesn't have capacity, you can communicate with them all you want, but all the decisions that you're making are not really going to be valid, because they're not in a position where they're able to understand, retain, and make an informed decision. And time again, when you're in the hospital, especially when you've got older patients, might be a bit confused, you will get a lot of staff members, from nurses to senior doctors to physiotherapists, asking you, does this patient have capacity? So you sort of need to understand what capacity is to be able to, I guess, answer that question. So when we're going on about capacity, this is from the GMC. So this will be available on the GMC. I will link everything at the end as well, and you'll get a copy of these slides. So when we're talking about capacity, you sort of have to start with the assumption that every adult has the capacity to make their decisions about their treatment, right? You shouldn't make assumptions, oh, this person doesn't have capacity just because they're old. Maybe just how they look scruffy, they don't look put together, they don't look interested. Maybe if they're behaving odd or aggressive or whatever it might be, it doesn't necessarily mean that they don't have capacity. Or even if their beliefs don't match up to what's considered to be, normal beliefs, or they're not able to communicate with you, or they have a disability, again, it doesn't mean that they lack capacity. So any consultation, any approach to any patient, you always start with assuming that they have capacity to make their decision, unless they prove you wrong or prove you otherwise. So a person has capacity if they can do all of the following. So can they understand all the information that's been given to them with the decision that's in question? Are they able to retain that information? So can they, it doesn't necessarily have to be word for word, but can they sort of retain that information and relay it back to you? This is what you've said, these are the pros, these are the cons. And then that sort of takes us on to the next position. When we say use the information to make their decisions, are they showing that they can weigh up options and then communicate a decision? It doesn't always have to be verbal, because not everyone's going to communicate verbally. But if they're able to communicate their decision, whether it's written through a diagram, then we can sort of say, so I've got a question here. How do you test retention in a subtle manner? So it doesn't always have to be subtle per se. There's a lot of assessments that you can do. So I haven't really covered it. So if it's an older patient, there's a few questions that you can sort of, well, you can just ask them. So do you understand, what I've said? And then just talk to them. And a lot of the time, patients prefer that you're honest with them, and that you're just like, oh, I just want to make sure you understand what we've spoken about. So you can say, so what do you think of what we've discussed, And then a lot of the patients will be able to, if they've retained that information, be like, yeah, I understand what you've said. You've said X, Y, Z, but, I'm of this belief, so X, Y, Z. So that usually covers all of the 3-4 points that are already there. You don't always have to even be, like I said, subtle. You can just be upfront, be like, I know I've given you a lot of information and it's a lot to take in. You can give them some leaflets as well. You can be like, I'll come back later and we can sort of rediscuss. And then when you rediscuss, you can be like, so what do you think? It was a lot. And they will sort of repeat the information back to you. So if they're repeating the information back to you, then you probably can figure out that they have this ability to retain that information. I hope that's answered your question. Okay, so when you approach a patient, always assess the capacity to make the patient's capacity to make the decision at that particular time. Just because a patient lacks capacity at that moment in time, it doesn't mean that they're not going to have capacity in the future to make, or just have capacity to make any decisions at all. So at that moment in time, if you've got a patient, an elderly patient who's got a bit of a, let's say, UTI, who's a bit confused, maybe hallucinating or delirious, doesn't know what's going on, at that moment in time, yes, she might not lack the capacity to make such a big decision, for example, maybe pertaining to a big medical decision outside of her UTI, or where she wants to go home when we discharge her. However, she might still have capacity to make day-to-day small decisions, like what she wants to eat for breakfast. And again, usually if someone's acutely confused, in the moment confused, and you feel like the confusion will clear, some conversations, if it can wait, you can wait to have those conversations, because again, just because they're confused now, it doesn't mean that they're going to be confused later. If they're confused because of an infection, once the infection clears, then they will sort of start going back to their baseline. And yeah, so just because someone might not have the capacity to make complex decisions, could be for a number of reasons. It doesn't mean that they can't make day-to-day decisions. And some people might know, like, I want to go home, you know, or this is where I want to be, but they might not be able to do all the things that show that they have capacity, which is a bit more complicated, and but it's a multidisciplinary sort of approach that you take. So this is where the multidisciplinary stuff comes in. So if you find it hard to determine whether the patient has capacity to make a decision, ask for help. There's always, and this goes for anything in the hospital, anything in medicine, especially as a junior, or even when you're a senior, there's no one looks down on you for asking for help, because you'd rather ask for help and do it the right way than make the wrong decisions. So someone who might know them well might be, for example, the nurse looking after this patient. So if the nurse has seen this patient from when they've come in to this point where they feel like they don't have capacity, they will be quite vocal, be like, something's happened, patient's confused, or I feel like patient doesn't have capacity. Even physiotherapists, if they're seeing the patient day to day, they'll be able to sort of voice that to you. And even family members, they'll be able to tell you, this is not, my dad, my mom's, my brother's baseline. Usually they're very with it. Right now, don't know what's going on. So in that sense, you can sort of get an idea, okay, this is not the baseline, doesn't seem like the patient has capacity. And again, if it's still complex and you're not sure, you can ask psychiatrists if you feel like, there's something else going on. Neurologist, if all of a sudden they're having expressive dysphagia or something, making communication difficult, SALT. Physiotherapists, nursing staff, senior consultants, maybe that have known this patient very, very well. Yeah, and always seek input if the patient or someone close to them disagrees with your judgment. So if you're saying, I think the patient lacks capacity, but the patient's like, no, I don't, or someone close to them, like their relative or next of kin, is telling you, no, this is their baseline, or this is how they are, these are this is what they want. Always seek, a second opinion, go to your seniors, ask around. There's nothing wrong with that. And remember, just because it's not a sane decision or what's classified as what's the normal thing, even if it's refusing treatment, it doesn't mean a patient lacks capacity. Some patients will refuse treatment, and they will have perfectly, normal capacity and the ability to make decisions. People will want to go home and self-discharge despite you explaining why they're here, and they might be very unwell, and all those things, but they'll just want to go home and they know exactly what you're talking about. They're able to retain that information. So yeah, if you've got any questions, put it in the chat if I'm going too fast or anything unclear. And obviously there'll be the Q&A at the end where you can ask any questions you come up with later. So documentation, very, very important. SALT is speech and language therapy. I should have written that down, but you'll hear a lot of SALT. So you can go to SALT for things from if a patient has communication difficulties, or you feel like they have swallowing difficulties, you go to SALT. If you feel like they might have had a stroke and they find it difficult for the language part, you can go to SALT. So SALT does quite a number of things, but they're a part of one of the teams that you'll come across, and they're very, very useful and helpful. So documentation, it is very important that you document, especially for the big decisions, not things like, oh, what do they want to eat for breakfast? But if you're having a conversation, for example, about their treatment, or about, when they get discharged, where do they want to go? Where do they want to go? Do they go to, if it's a palliative patient, do they want to go home? Do they want to go to a nursing home, or is it something that they definitely don't need? So you have to make sure your assessment is very clear. You document it in the medical notes. So things you have to include are assessment, the indication for assessment, date, time, who was present, and what your decision relates to. So a lot of trusts. So at my current trust, some of the wards, this is just something that I got off the internet, the 2 screenshots, but different trusts have different things. So when I was doing my F1, F2, the trust that I was at, they had stickers. So you would stick the sticker in, you'd write what the decision is. So I don't know, patient to go home. And then you sort of go through the questions, and they'll go through the questions. Can the patient understand, retain, weigh up their options? Can they communicate? And in some trusts, they'll ask you to justify these. How are they able to understand? How are they retaining the information? So you might write able to, what's the word? Able to tell you what you've told them, and weighing out options, able to understand the pros and cons, was able to give reasoning about why this option, is not suitable, communication, verbally communicate. So, and then they'll have like, if they don't lack capacity, who else was there? What's your conclusion? So, and some trusts or some departments will have a piece of paper, double-sided. It might be a bit more simpler. You just fill that form in for that decision. So it doesn't mean that this stays in place forever, but it just means for this decision at this moment in time, in the patient's current condition at that time, this is what they said. Or I felt they had capacity because of XYZ reason, therefore the patient would like to go home. Or patient doesn't have capacity, has vascular dementia, next of kin was consulted with, we had a whole discussion, this was the outcome of the discussion. And some people will have sort of lasting power of attorneys, or power of attorneys relating to their health decisions. So that's also important to check. So people that might have Alzheimer's, dementias, they might already have someone in place that have the ability to make the medical decisions, in which case you'll consult with whoever has that power. Some people would have already expressed, you know, if it gets to this moment in my life, this is what I would like to happen, or in this situation, this is what I'd like to happen. So sometimes it is important. It's not always just the patient. You'll get sort of an overall view with the patient, with the patients, relatives, next of kins, whoever has power of attorney. And always remember, capacity can fluctuate sometimes, and a lot of the time, especially with acute admissions in the elderly. So it is important to document whether the patient has capacity for certain things. And if you feel like at that moment in time the patient doesn't have capacity, let's go with the UTI sample, but you feel like this is not an urgent decision, it can wait until the patient's improved and they've sort of come back around from their confusion. You can also document, you know, like can revisit in a few days when patient's UTI is resolving. But right now, the patient doesn't have the capacity to make the decision. I hope that makes sense. I know it's a lot of information, but again, a lot of the trust, a lot of the hospital have these capacity assessment forms that you can just fill in. And a lot of the time we fill their stuff in for very big decisions, day-to-day decisions, what they eat, what they do. It's usually up to them. We don't really get involved, and most patients will know their day-to-day stuff, but it's the big stuff, treatment, going home and things like that. You fill in these capacity assessment forms. So we can now assess whether a patient has capacity or not, which is very important, and it's important to every aspect of everything else, because even breaking bad news, you have to again think, does the patient have capacity? If the patient doesn't have the capacity to retain the information or be able to understand what's happening to them, there is no point breaking the bad news, because they won't remember anything or they won't retain anything. So again, like I mentioned, the capacity thing plays into pretty much most parts of what you do in your day-to-day medicine. So just in the chat, how would you say you'd break bad news to someone? Remember, there's no wrong answers. Feel free to write whatever you think is the best way to break bad news. So in a quiet room, ask if they have questions. Yeah. Anyone else brave enough? Sitting down. Yeah. Having tissues nearby. Spikes. Yeah. Lots of good answers to settings, perception, interpretation, knowledge. So it seems like a lot of you sort of have an idea of how to break bad news. I think breaking bad news, no matter how long you've been working, doesn't get any easier. It might just get easier for you to pluck up the courage to do it, but it's always something very, very difficult to do. Every patient is different, every family is different, so no two scenarios of breaking bad news is the same, but you just try to keep to a format that basically gives you, you know, you can do it in a respectful way. But again, like I said, you just don't know how people are going to react, and you sort of have to be ready for anything. And breaking bad news doesn't always happen in the hospital, it can happen in primary care settings too. And I think when you're starting off as juniors, I know at least when I was starting off in my first job, I just didn't even know how to go about it. Yes, theoretically, you learn how to do it, or this is how I would do it, but you just don't know. So I found what was helpful was, especially if it was breaking bad news, or you know your registrar or consultant is going to talk to a patient about, I don't know, a CT scan that might have shown some masses, or which is essentially breaking bad news. Just go with them, stand there, sort of see how they approach the situation, how they break the bad news, how they tackle the reactions, because there's no, and everyone does it differently. So you can pick up the good points or the things that you like that you can put into your sort of own way of breaking bad news to patients. So initially, I started off just by going with seniors, and usually most bad news will be broken by registrars or consultant. However, there will be times where you might be caught off guard and someone's like, oh, have you got the results of my scan yet? Which you'll have to give. And then obviously as you work your way up and you get a little bit more senior, you're having to have these discussions more often. But yeah, initially when you're starting off, especially if you're not comfortable, just tell your seniors, I am not comfortable breaking this bad news. I've never done it before. Can I come with you and watch how you do it? And people will be more than happy to help you or go have you go with them. Don't feel pressured to do something you don't feel comfortable doing, especially if you don't know how you're going to answer any questions and things like that. So be vocal. If you're not comfortable, don't do it. The first few times, watch. And with anything, I think when you're starting out, watch one, do one is a good approach. Even if something as basic as taking bloods, watch one and then you can do the next one, because it will just give you that confidence. So rightly so, like someone mentioned, we're going to go through the spikes format. So I just got this from my Instagram page. It's all there if you guys want it, and you'll get it in the handover. So the usual is, wash your hands, make sure you have the correct patient, confirm their name and date of birth. And believe me, it happens more often than you think. There have been situations in the time that I've been working as well where someone's accidentally told the wrong patient the wrong results or broken the wrong news, and it can be quite distressing for patients. So it's very important to make sure that you confirm that it's the correct patient, check their name, check their date of birth, see what they want you to pull them. I mean, if you've already got a relationship with that patient, you might already know these things. Just sort of, there's something really important for us to discuss. Are you happy to discuss them? And just sort of also explain that, everything we discuss is sort of between us. I also like to give the option of giving them a bit of a heads up and asking, would you like I guess it goes into the settings part, but just being like, before you even start the conversation, being like, because this is such an important conversation, would you like, one of your relatives or next of kin sort of to be present? So then that sort of sets you up to your spikes format. So S is for settings. So you got to make sure the setting is correct. A busy corridor with no privacy is not the place to have a conversation when you're breaking bad news. Some preferably should be somewhere quiet, private, where no one disturbs you. Make sure that your phone is turned off or on silent, so you're not getting interrupted during this conversation. If you're in a room, just let everyone know, or put a sign up, family discussion or something at the outside the door, just so no one's knocking on the door every 2 seconds to try and get a piece of paper, or and we've already sort of covered asking the patient if they want the relatives there. And usually the best way to do it is to make sure that you have no barriers. It's like an open space, maybe that there's not like a desk or something blocking the between you and the patient, because sometimes the physical barriers, it's all about body language, how you're presenting yourself. The physical barriers, although the physical barriers can add to being emotional barriers as well, where they feel like they can't communicate with you because you've actually got something blocking your way. So P, perception. Never go in just, all guns blazing, this is what it is. Sort of ask, so what do you've been in hospital for a while, and we've had a few tests. What do you sort of understand what's been going on up till this point? You know, some patients will tell you exactly what they feel like is going on, and be able to tell you A to Z. This is what's happened, this is the scan that I have, da, da, da. Some patients will be like, oh, I don't know, I had this scan, they said something about this, and you sort of fill in the gaps, reassure them, make sure you know what they already know, so you know exactly what amount of information to go give them. And also the perception part, it helps you to understand maybe the level or the way you should deliver the information. Not everyone's able to sort of understand everything. Some patients will take you explaining it in 5 different ways, or breaking it down very, very simple bits at a time. So the way they're talking, communicating, or their level of understanding prior will help you indicate what you need to do and how much or how you should be delivering this information. And give them a warning. So, you've had the scan, doesn't look good. So a warning. So then, and then a pause, just sort of let them process what you've just told them before you go into the next part. You can sort of be like, and then you invite them. Do you want to know? You had your CT scan. There are things that have shown up. Would you like to know? Would you like me to explain it to you today, like now? Or do you want to sort of, should I give you some time and we can have this conversation later? And again, I know you're by yourself. Would you like someone present? Is always just, or continuously ask them, do you want someone here? Because at different points of this conversation, it's a very emotional conversation, and some patients can get emotional. They might start off by saying, nah, I'm good, I'll have all the information, like I can deal with this myself. But then maybe at this point they'll be like, actually, since it's not looking like good news, yes, I would like my family present, they're coming in during visiting hours at 2 o'clock, can we have the conversation then? In which case you're like, yeah, no worries, we can have the conversation then. Okay. Knowledge. So knowledge is very important. Like I mentioned before, when you're doing the perception part, you'll sort of get an understanding of how you need to deliver the information. Even in the patients that feel like that are very high, can retain quite a lot of information, seems like they, that they know what they're talking about, they're able to retain quite a lot. It's still very important when you're breaking bad news to deliver it in small chunks and pause between each sort of delivery to allow, if they've got any questions, just let them answer the questions. Keep that flow of conversation going. Check in on whether the patient understands. So it could just be, the CT shows the masses. Do you understand what I mean by masses? Even little things like that. Because sometimes you'll be surprised that, oops, sorry guys, I've just been told I've only got 10 minutes. We've got quite a bit to cover, so I'm gonna try and rush through. So the results are not what we hoped. You can say things like that. Use simple and easy information to understand. So emotional, just always look at sort of how they're feeling, read their body language, be empathetic, just acknowledge how they're feeling. Don't dismiss feelings. Like, you have every right to feel how you feel. And don't lie. You should always be honest, because the last thing you want to do is like, oh yeah, the prognosis. If they ask you, is the prognosis bad? If it is bad, tell them it is bad, because like I said in the beginning, patients love honesty, or they'll appreciate you for being honest, because the last thing you want to do is give them false hope. So yeah, strategy and summary. So this is a bit of a, again, summarize, just bringing the conversation to an end. Do you understand what's been done? Don't rush them. Do you need time to think about this decision? Check that they've understood what you've said, answer any questions, and think, what is the next step? Should we rediscuss this? Should we revisit this? Do you want some time to think about it? And then we can talk about the next steps. So those are the sort of things that you're doing in the summary and strategy. So yeah, DNA CPR decisions. Again, why do we have them? So most trusts, I believe, or at least in my trust, every person that comes into hospital, no matter how young, no matter how old, you have a form that we fill in for do not resuscitate. Whether they are for resuscitation or not, you fill the form in, and DNA CPR just makes sure that patient has a dignified death, and that we make sure that should it come to that point, again, just because we're putting a DNA CPR in place, it doesn't mean that we're going to have to use it, but it's just something that we have to do. And it ensures if it gets to that point, patients' wishes are met and they have a dignified death. So a do not resuscitate should be considered when a patient with capacity doesn't want CPR. So if someone doesn't want CPR, fine, you don't want CPR, that is fine. Or if someone has dementia, but previously they've had a DNA CPR decision in place and doesn't want CPR, that's fine. You fill that form in, not for resuscitation. If the burden outweighs the benefit, so if there's more, we will resuscitate you, but there's no essentially point, or if CPR is ineffective, essentially if they've got a lot of irreversible conditions, they're for example, at the end of, they've got metastatic cancer, is spread everywhere, they're essentially dying, no amount of resuscitation is really going to be effective. So these are the times when you might think about making someone not for resuscitation if they don't already have a resuscitation in place. I think what I found with these conversations about CPR is the lack of understanding. So I think a lot of people think if you say you're having a discussion about CPR, they think if you're not for CPR, then automatically they get no other treatments should they deteriorate. So it's important that you make sure your patients understand what is CPR. So you explain, CPR is an attempt to sort of restart your heart if your heart stops. So the DNA CPR only is a decision about your heart if it stops. It's an invasive process. It involves chest compressions, ventilations, IV drugs. You also make it clear there is a low chance of success rate. It carries risk. If your heart stops, you don't have enough oxygen, then you get hypoxic brain injury. And the thing is, say you are lucky and we are able to restart your heart, there's no guarantee you will be the person that you are today. Sometimes it's a medical decision, like you've got too many comorbidities, you're at the end of the life, the resuscitation risks are very low. So we think you shouldn't be for CPR. But a lot of the time, again, a lot of people, what I found is when you say not for resuscitation, they automatically think they have access to no other treatment. So it's important to clarify, just because this is just for your heart if it ever stops, it doesn't mean that we're not going to give you, IV antibiotics for an infection. You're not giving it sort of giving up, and just reassure the patient, just because we're having the discussion, it doesn't mean, someone could have just come in with a bit of a skin infection. It doesn't mean it's going to go this way, but it's something that we have to do as a part of our paperwork and ensure that when you're in a condition to make these decisions, that you're able to make these conditions so your wishes are met, should it ever get to that point. And just ensure, you know, a lot of patients like their family to be present, next of kin to be present. So make sure that they're all there and gain permissions. Like, okay, so we've had this discussion. Is it okay if I just put it down on the form? This is what I'm going to write. Is that all good? And I'm going to sign the form. And most patients will be happy. Sometimes patients, if they've never had to think about it, will like some time to think about it, which is fair enough. So you give the information. Sometimes there's even a leaflet you can give them that. I'll come back and we'll have this discussion, you know, tomorrow or later on today after you've spoken to your family. Is that all right? Because a lot of people, until they get into hospital, would never have even thought about these things. So don't rush patients to sort of make these decisions. Typically, this is what a respect form looks like. So again, for CPR, not for CPR, and you can sort of, you know, make it customized to each patient. So, you know, for ITU, so they can have all the types of care, so they can go into ICU, but they don't want CPR. So, you know, and each patient is different. Some patients will be like, yeah, not for anything. I just want to be comfortable. Some patients will be a balance of the both. So it's important to understand that, you know, you have these conversations and they understand, and make sure you know what the patient's wishes for. And there's a bit about capacity. A lot of the time, if you're having this discussion, they do have capacity. And if they don't, they might already have one in place. Like quite a lot of dementia patients already have a DNA CPR in place. Make sure it's signed by yourself. And then you got to make sure, I think, it's signed by a consultant. Otherwise, it's not valid. So that's the main thing. It's valid for, I think, 24 hours or something. Without consultant signature, but try and get the consultant signature as soon as possible. So SBAR, we're going to run through this quite quickly. SBAR is quite important because I think it takes a lot of practice. So it's situation, background, assessment, and recommendations. So it's a good work communication tool that I think you will all find very helpful, and it helps to convey important information that you need advice for. And it's not something that you're going to be immediately good at. When you're starting off, it will take you time, but eventually when you're doing it time and time again, you'll get very, very good at it. So there's something I'm sure you're all aware of osmosis. So situation, so introduce yourself, why you're calling, who it's about, give a bit of background about the patient, what they've come in with, when they were admitted, the diagnosis, past medical history, any investigations you've got, what's changed. Assessment, that could be what you've assessed the patient. This is what's happening. I've done A to E. You know, I'm very worried, and sort of make it clear what you want. I need some advice, or, you know, what antibiotics should I start, or could you please come and review the patient immediately? I'm very, very concerned. That's just a very short summary of what the SBAR is. And everyone has their own unique way of doing it. This is just a template to help you, but essentially if you're including all that information, and it will become natural the more you do it. So preparing for SBAR is, again, takes practice to give a good handover. So always practice and use any opportunity to practice. So you might want to start with a conversation to microbiology before you're on call, you know, because on call, things that you might have to do an SBAR about might be a bit more urgent, whereas everyday small conversations that you have to have, whether it's with microbiology or getting advice from a different speciality, use those opportunities to practice. The first time will not be perfect. And to be honest, even throughout your career, it won't be perfect, but just make sure you give yourself enough time to prepare. If you need a piece of paper to write down everything, because sometimes, you know, patients might be in for a long time. So if you need to write a quick summary, the latest bits of information you have, do so before you make the phone call, because then it's useful for the person on the other side as well, because then you're being very efficient. You're passing information efficiently from person to person, and you're making sure nothing is missed. Especially those microbiology conversations, SBAR is very important, because they haven't seen the patient, so they need sort of an accurate account of what's happened, you know, their clinical status, maybe how many antibiotics they've been on and for how long, and, you know, how does the patient look. I like to always be in front of a computer, so I have access to any sort of labs or investigations that I need, because sometimes they will ask you, oh, what was the latest bloods, or oh, did they ever have a chest x-ray or a blood culture? So have access to all that. Also have the patient's notes, because they'll ask you really random questions that you might not be prepared for. So it might be worth just having the patient's notes so you can quickly flick through them. And it's okay to be like, give me a second, I'm just going to look through the patient's notes, I'll let you know. And people are happy to wait. I think it's just making sure that information, you give the accurate information. You don't want to say, oh yeah, the inflammatory markers are fine, if they're not fine, because then that will change the patient's management. So again, SBAR, the more you do it, the better you get. And even if you've got good at it, there will be times where you're caught out. But these are all things you can sort of do to give yourself maximum sort of opportunity to make sure you hand over information correctly. Even if you're on call, SBAR is very important when you're handing over, say, an unwell patient before you know, say, for example, you're on call, you're handing over to the night team. SBAR is very important. This is the patient, this is what they've come in with, this is what's happening, you know, I've done X, Y, Z. I need you to go and chase these results, or I need you to chase this CT head. And, you know, based on the results, this is the plan that's in place. So this is an example of, I guess, phrases and words and background and things you can sort of use that I found off the internet. So you can sort of, you know, pick and choose which ones you want and use the ones that you would like, until you get your own method of sort of saying these things. So again, family updates. I think this is the last bit, so I should be done. To give family updates, it's a combination of everything we've sort of discussed. So I like, even to give family updates, it's good to use the spikes format, you know, because you can apply the spikes format to everything, not just breaking bad news. The main thing is, don't assume just because they're family that your patient is happy for you to give updates. Always ask the patient's permission. You will come across a lot of funny family dynamics, or very complex family dynamics, just because they call in and they say, oh, you know, I'm so-and-so's wife or husband or daughter. Do not assume that it's okay for you to give updates. Ask the permission. Hey, I've got your daughter on the phone asking for an update. Are you happy for me to give an update? And then make sure you document, you know, the patient is happy for us to update, you know, Deborah, her daughter, at any given time. Just so it's in documentation, so it can't come back on you, because there'll be times where they'll be like, you can update this person but not that person. Like I mentioned, you can apply the spikes format, just make sure the settings right, have all your information, break it down in chunks, see what they already know before you start, you know, bombarding them with loads of information. Summarize, plan, answer any questions, and document every single family discussion that you have, especially if any concerns are raised. That's very important, because if a complaint is made, you need to make sure that you've documented, you know, you've had this discussion, you know, I've answered these questions, the family was happy at the end of that discussion, this is what they've said, this is what they'd like. So make sure that you document these discussions. A lot of the time, it's a part of what you have to do, and it won't come back to you. But there will be the odd patient or family that makes a complaint that, you know, these sort of discussions are very important to have documented, because you don't want a lot of he said, she said it, because it just makes things a lot more complicated. But as with anything, any important discussions you have, regardless of whether it's updates or just anything, whether even it's with the patient, just document everything and clearly exactly what was said, what, you know, the patient would want, and what was the outcome of the conversation. So I always like to write, you know, patient and family happy with updates, no questions or concerns voiced at this moment in time, and sort of leave it at that, especially if they were happy and okay at that time. So these are just some of the references that I used. Geeky Medics will be your best friend, especially throughout your junior years and even now. BMJ has very good things on communications, DNA CPR. Same with the GMC ethical guidelines, especially on capacity, which is so important. So those would be my go-to website, and I'm sure there's loads more, but I generally go BMJ, GMC, Geeky Medics. They're probably my top 3. I think that is the end. I know I rushed through the S bar and things, but you know, we can go through that. I did want to include some clinical cases and maybe practice a few of these things, but maybe that's something for another time. I guess let Next Step Medics know if you want sort of practice sessions of how to communicate and have these sort of difficult discussions and scenarios and sort of play stuff. But yeah, thank you for listening, and thank you for getting involved.